So, hi guys, we're back with another video on the neurolocalization. This video is going to basically cover the neuro cases and neurology regarding localization of lesions in the brain. Okay, so basically let's start off with neurolocalization. Usually in neurology, you get a patient who presents with symptoms, okay, and the job of the neurologist is to find the cause of these symptoms, all right, by finding the area where the damage has occurred. So the main questions we're going to ask in neurology are basically, is there a neurological problem in this patient? Where is the problem? And what is the problem? So, in this slide, we're going to go through the basic anatomy of the brain and the spinal cord, okay? As we can see, the brain consisting of the cortex, which is external, okay? And from the cortex, the neurons, all right, come together to give rise to bundles, okay? These neurological bundles give rise to tracts, okay? In this case, the tracts, all right, here, are showing the cortico-spinal tracts. So the cortex, all right, the neurons will give rise to a bundle, a cortico-spinal tract bundle, which tends to pass through the midbrain and the spinal cord, okay? They decussate at the pyramids, all right? They go down into the spine and they come out into the neurons, the lower motor neurons, to the skeletal muscle. The brain, or our nervous system, okay, is made up of a central nervous system, which consists of the brain, the cortex, the basal ganglia, the cerebellum and the brainstem, and this continues as the spinal cord ending at level of L1. So L1 is the final level where your CNS ends at, okay? The peripheral nervous system, on the other hand, consists of the pathway from the anterior horn cell down to the muscle, okay? It consists of the anterior horn cell, the root, the plexus, the nerve, the neuromuscular junction, and the muscle. These are all important towards pathology, and in the coming slides, we're going to see why these are so, okay? Motor tracts. So, as we said before, when we have a patient presenting with a motor deficit, the problem, okay, can be anywhere in the CNS or the PNS. It can be in the central nervous system or in the peripheral nervous system. So the damage can either be here at the cortex, it can be here within the matter of the brain, it can be at the midbrain, the pons, the medulla, the spinal cord, or in the lower motor neurons, okay? So this entire thing here is a tract, okay? It is a motor tract originating from the motor nerve cells, especially in the primary motor cortex. They go down into, again, the midbrain, the pons, and the medulla, where they decussate at the pyramids. They come down to the spinal cord, okay? They give rise to synapses, and these become, okay, the lower motor neurons, which supply the muscle groups. Now, this diagram over here is we're looking at basically how the cell of the upper motor neuron supplies the other parts of the body, okay? The motor cortex here, containing the motor neuron cell, the cell can either supply another anterior horn cell at the brainstem, giving rise to a cranial nerve, or else it continues down, it decussates, it goes into the spine, it synapses on an anterior horn cell, giving rise to a lower motor neuron. So the supply here, the nerve supply, all right, the upper motor neuron can have connections at two places, at either cranial nerves or at lower motor neurons. Both the cranial nerves and the peripheral nerves supplying the hands and the legs are considered to be lower motor neurons. Again, both the cranial nerves in the face, the tongue, the eyes, the oculomotor, the abducent nerve, okay, and the nerves supplying the limbs, okay, are considered lower motor neurons, whilst an upper motor neuron is the primary cell body present in the brain. Tracts continued, we have again, they are subdivided into two main tracts, the corticospinal tract. This is a motor tract connecting the primary motor cortex to the spinal cord and eventually to a muscle, and the spinothalamic tract. The spinothalamic tract relays information from the body to the somatosensory cortex, and it is divided into a lateral and an anterior tract. The lateral tract transmits pain and temperature. The anterior portion transmits pressure and crude touch. So, another important aspect of our CNS, okay, is the dorsal column. Okay, the dorsal column, the medial lemniscus pathway, is important because it is a sensory pathway responsible for the transmission of fine touch and vibration sense, especially conscious proprioception. Okay? This is important. Why? Because proprioception helps us identify ourselves in space. Okay? So, with the loss of proprioception, you're going to get problems such as ataxia or instability. Right? These can be caused, for example, by deficiencies of vitamin B12, alright, or trauma or damage to the dorsal columns. Okay? It is important because the dorsal column is also creates a function of recognition of texture, okay, and 2-point discrimination. Okay, these are always tested in the clinical examination, okay, especially when carrying out a cerebellar examination. So, why is the blood supply important? Next on, we're going to move to blood supply. The blood supply of the brain, alright, provides the nutrition, okay, and the oxygenation to the brain system. The brain system, the neurons, cannot reproduce, okay. We are born with all our brain neurons and eventually they start dying off. Therefore, the circulation is critical to the functioning of the brain, okay. Our circulation in the brain is divided into 3 parts. We have an anterior circulation, we have the middle cerebral circulation here by the middle cerebral artery, the posterior communicating and the anterior communicating arteries, and the posterior circulation, which is given by the basilar, the superior cerebellar and posterior cerebellar. These supply different areas of the brain. The anterior circulation supplies the anterior aspect of the brain. The middle cerebral artery supplies the lateral aspect of the cerebrum, and the posterior circulation supplies the posterior brain and brainstem. Okay? Now, any occlusion occurring in the posterior aspect will target the cranial nerves. So the cranial nerve blood supply will produce different cranial nerve palsies or pathologies because there is damage or occlusion of a vessel affecting the area, okay, where the cranial nerves or the cranial nerve nuclei are affected. The third and the fourth cranial nerve nuclei are usually present in the midbrain and they are supplied by the posterior cerebral artery. Okay, an occlusion of the third and the fourth will give rise to a third and or fourth palsy. Okay, the fifth, the sixth, the seventh, and the eighth are supplied by the basilar artery and are located in the pons, whilst the ninth, the 10th, the 11th, and the 12th are supplied by the vertebral artery, and this is located in the medulla. So, cerebral hemispheres. Okay, our brain, as we said before, is supplied by the circulation. It has an anterior, a middle, and a posterior circulation. The anterior circulation tends to supply the medial aspect or surface of the internal capsule and the medial aspect of our brain. The middle cerebral artery usually tends to supply the lateral surface of the brain hemisphere, the basal ganglia and the internal capsule, whilst the posterior circulation tends to supply the posterior brain, especially the visual cortex. So, the first thing we're going to try and exclude is whether the lesion is upper or lower motor neuron lesion. So a good mnemonic for medical students is that of storm baby. Okay? Storm baby, alright, helps us differentiate whether it is upper motor or lower motor neuron. It basically means strength, tone, others, reflexes, okay, deep tendon reflexes, DTRs, muscle mass, and Babinski sign, storm baby, with baby for Babinski. In upper motor neuron lesions, where the lesion would be usually in the brain, okay, in the cerebrum or the cerebral cortex, the strength will be low, the tone will be increased, there will be superficial reflexes or conus, for example. We have reflexes that are increased, there is a slight loss of muscle mass, which is only slight, and we have a positive toe up Babinski sign. Lower motor neurons, the strength is lower, low strength, there is a decreased tone, flaccidity, okay? We have usually presence of fasciculations or fibrillations, there is a decrease in reflexes, and the muscle mass is atrophied or decreased. Babinski is negative. Upper motor neuron lesions, the pattern of weakness is usually caused by damage anywhere along the corticospinal tract or the pyramidal tracts, which start in the brain at the cortex, and they keep on going down to the neuromuscular junction to the muscle. Upper motor neuron weakness affects usually groups of muscles rather than a single individual muscle itself, typically in a pyramidal fashion, okay? So, unlike the lower motor neurons, for example, if we have a third nerve palsy of the eye, okay, it usually tends to affect the lower motor neuron, a single muscle group, a single type of muscle, for example, the rectus muscle, or else it can affect, for example, our trochlear, okay, muscle, or it can affect, for example, the facial nerve, affecting a single particular movement in the face. But the upper motor neuron lesions usually affect a group of muscles. For example, they can affect the entire limb or hand or, for example, both limbs at the same time. Okay? The lower motor neuron lesions are caused by damage anywhere from the anterior horn cells distally, including the nerve roots, the plexuses, and the peripheral nerves. The affected muscles show wasting and fasciculation. There is hypotonia, therefore the muscle is flaccid or there is no tone. The limb feels soft and floppy, okay, and provides very little resistance towards a passive stretch. Reflexes are reduced or absent and the plantars remain flexor. They are usually in the lower motor neuron, they flex and therefore they are normal. There is a negative Babinski sign. So, when we have a patient presenting with a sudden onset, acute, alright, clinical presentation like weakness in a limb, we have to differentiate whether this is a stroke or whether this is a transient ischemic attack, a TIA. A stroke is a cerebrovascular accident that causes progressive neurological signs lasting more than 24 hours, whilst a TIA is a transient ischemic attack, which is an episode of ischemia, and the signs are there for less than 24 hours. Again, why is it important to find what type of stroke this is? Okay, usually when a patient presents with a stroke, we usually carry out a CT scan, okay? And most of the times, the strokes are usually going to be ischemic. However, at 20% of the occurrences, strokes are usually hemorrhagic. The importance of this and the importance of doing a CT scan as fast as possible is this affects treatment of the stroke. Okay? In this case, this is a CT scan of a brain with ischemic stroke. Okay, as we can see over here, whilst this is hemorrhagic. Treatment is important, of course. Alright? And the way in which we treat the stroke can have a big impact on the patient's outcome and prognosis. Usually, strokes might be caused by hypertension, and blood pressure should not be lowered in the first few days of an ischemic stroke unless it is extremely elevated. Why? Because medically induced hypotension by the drugs we give to the patient can exacerbate the focal cerebral ischemia. We can make this ischemia even worse, and worsen the neurological prognosis or outcome. Treatment of an ischemic stroke starts off with the assessment for eligibility of thrombolysis. So when the patient presents with a stroke, and after we do the CT scan, we're going to state whether this patient is eligible or not for thrombolysis. Treatment must be initiated urgently, and intravenous tissue plasminogen activator or TPA can significantly improve the odds of a neurological recovery. It must be administered importantly within 3 hours. So, TPA is associated with an increased risk of intracranial hemorrhage, and this should be kept in mind. Symptoms. Okay, so depending on the area of the stroke or of the lesion, we can have a tumor, not only a stroke, alright? We can get various symptoms that can help us point towards the area of the deficit. For example, if we have the frontal lobe affected, there might be a change in the person's personality, for example, a loss of social awareness, disinhibition, emotional instability, irritability, or impulsiveness. If the hemispheres are affected, in the right hemisphere we would get a left hemiparesis with a left hemisensory disturbance and a left upper motor neuron facial weakness. Also, it might present with a left homonymous hemianopia, which is contralateral to the right lesion, and the hemineglect might be present, especially if it is non-dominant, if the hemisphere is non-dominant. The left hemisphere usually presents with a right hemiparesis, a right hemisensory disturbance, a right upper motor neuron facial weakness, a right homonymous hemianopia, and dysphasia or aphasia. The left is usually the dominant hemisphere. Therefore, we get the dominant speech areas which result in the dysphasia or the aphasia. An occipital damage, like a tumoral lesion or a stroke, may cause homonymous hemianopia, visual agnosia, scotomas, hallucinations, okay, etc. A cerebellar cause may result in a dysarthria, dizziness, nausea, vomiting, ipsilateral, or unsteadiness in the gait. So, areas of lesion. Okay? When we talk about which areas the lesion is in, we can exclude or include certain aspects of the brain depending on the area of the lesion. For example, the symptoms in the parietal dominant side are going to give us a dyscalculia, dysphasia, dyslexia, apraxia, or agnosia, and importantly, homonymous hemianopia. The dominant side is usually responsible for calculation language and planned movements, appreciation of size, shape, weight, and texture. The non-dominant is usually involved in spatial orientation and constructional skills. So, in the non-dominant aspects of the hemisphere, we will get a neglect, a spatial disorientation, dressing apraxia, inability to dress or to lock their buttons, and the homonymous hemianopia. The occipital usually would give us a homonymous hemianopia with visual agnosia and visual hallucinations, such as lights, zigzags, or lines. Okay? The temporal lobe, okay, is involved usually in auditory perception, speech, language, verbal, memory, and smell. Lesions within the temporal lobe, within the dominant side, can give us dysphasia, dyslexia, poor memory, complex hallucinations with sounds or vision, especially because it is affecting the temporal lobe. And the non-dominant side will give us poor non-verbal memory loss, complex hallucinations, and homonymous hemianopias. Which vessel is occluded? We have 3 vessel territories, the ACA, the MCA, and the PCA. The ACA would give us a contralateral weakness in the lower limb more than the upper limb, with a contralateral sensory loss. There might be urinary incontinence and dressing apraxia. The mid-cerebral artery can give us contralateral hemiplegia, mostly in the upper limb. Contralateral sensory loss, gaze deviation towards the infarct, it is important, the eyes deviate towards the lesion, a contralateral hemianopia without a macular sparing, and neglect in the non-dominant hemispheres, and aphasia which occurs in the dominant, being a Broca's or a Wernicke's. The posterior artery will give us vertigo, nausea, vomiting, Alright, signs of posterior occlusion, contralateral sensory loss, and the contralateral hemenopia with macular sparing. It is important that in the posterior circulation we get macular sparing. Brainstem lesions. So the brainstem lesion usually tends to produce a specific sign, usually resulting in an ipsilateral cranial nerve sign and a contralateral long tract sign. For example, usually lesions occurring in the midbrain will affect the nuclei of cranial nerve 3 and 4, resulting in a vertical gaze palsy or a contralateral weakness. In the pons, you're going to get affected usually the cranial nerve 5 and 8, resulting in a horizontal gaze palsy, an ipsilateral cerebellar sign, and a contralateral weakness. The horizontal gaze palsy is usually due to cranial nerve number 6, abducent nerve. Whilst the medulla, where we have the cranial nerve 9 to 12, we're going to get bulbar signs. Alright, cranial nerve signs plus bulbar signs with nausea, vomiting, and sensory deficit. So, when trying to find out the cause of a lesion, we're going to use the acronym called vitamin. Vitamin stands for vascular, inflammatory, toxic, autoimmune, metabolic, idiopathic, or neoplastic. So, what is the cause? When in your clinical examination they're going to ask you what is the cause, you can always use the term vitamin. Vascular means usually acute and usually less than 24 hours. It can be inflammatory, therefore it might be long-standing or chronic. Toxic, autoimmune, like for example Myasthenia gravis, metabolic, idiopathic or neoplastic, like a tumor in the brain. The causes of acute setting usually tend to be vascular. Subacute settings are usually inflammatory, toxic or malignancy with spatial lesions, and chronic tends to be neurodegenerative, such as MS or ALS. For example, this is an interesting case. We have a 50-year-old female brought by her husband to the emergency department after experiencing a sudden onset severe headache associated to vomiting, neck stiffness with left-sided weakness. She noted to complain of the worst headache of her life. So in this case, the symptoms are pointing towards a specific type of cerebral lesion. With the current, with these symptoms, specific symptoms of sudden onset, severe headache, vomiting, neck stiffness, and having the worst headache of your life, they all point towards a subarachnoid hemorrhage. So, when we go about trying to analyze the case, we're going to think about what is the most likely diagnosis. In this case, it is probably a subarachnoid hemorrhage. The next step would be the diagnostic step. We would use a non-contrast CT for the brain. And the next step in therapy would be doing or undergoing cerebral angiography. So, the next type of lesion we would look into, alright, or talk about is going to be a myelopathy. Spinal cord lesions, the most common form of which are myelopathies. Myelopathies are usually injuries to the spinal cord due to severe compression that may result from trauma, congenital stenosis of the spinal canal, degeneration, and disc herniation. Usually myelopathies because, as we said before, the CNS, it consists of the brain and spinal cord. We're going to get upper motor neuron signs. These include weakness, spasticity, clumsiness, altered tonus, a tone which is altered, hyperreflexia, pathological reflexes, including a Hoffman sign and an inverted plantar reflex, okay, which is a positive Babinski. Now, depending on the level of the lesion in the spine, we can get different types of plegias. For example, at SE4, which is up here, alright, in the neck, we're going to get a quadriplegia or a tetraplegia resulting in a complete paralysis. If it is C6, we can result the same in a partial paralysis of the hands and arms. However, it might also result in a quadriplegia because it is a high up lesion. If we move eventually downwards within the 12th thoracic vertebral region over here, for example at around T10, we might get a paraplegia resulting in half paralysis in the lower limbs, okay, below the chest. Whilst if we hit at around L1, L2, alright, at the conus, for example, lumbar vertebra region, we might get a paraplegia resulting in paralysis below the waist. These are important when trying to identify where the lesion is, okay? So if we have a lesion in the cervical spine, we're going to probably get a quadriplegia. If it is in the thoracic spine, we're going to probably get a paraplegia below the waist, okay? Below the chest. And in the lower lumbar area, we're going to get a paraplegia below the waist. Now, we have syndromes which affect specifically the spinal cord. These syndromes must be differentiated, okay, from each other because of the severity. So the two syndromes which are usually present, alright, and usually affect the spinal cord include the Cauda equina syndrome and conus medullaris. So what is the difference between the Cauda equina and the conus medullaris? Anatomically speaking, the conus medullaris is usually the ending of the spinal cord itself. So here we are talking about a usually part of the spine, and therefore it is an upper motor neuron lesion, whilst the Cauda equina is part of the peripheral nervous system, alright, and consists mostly of lower motor neurons. Okay, so the lesion is usually lower till L4, L5, whilst a conus medullaris will be at around L1. Cauda equina syndrome, in fact, will be quite different in presentation to the conus medullaris. Usually it is unilateral because it is lower motor neuron. There is saddle anesthesia. There is an important asymmetrical motor weakness. There is hyporeflexia or areflexia because it is a lower motor neuron lesion. And there is late onset bowel bladder dysfunction, whilst in conus medullaris we have sudden onset severe back pain with perianal hypoesthesia. There is symmetrical motor weakness, which is symmetrical. There is, in this case, hyperreflexia because it is upper motor neuron. And there is early onset of bowel and bladder dysfunction, again, which is early onset. The treatment of these two conditions is usually surgical decompression. So basically, you refer your patient to surgery, you phone up neurosurgery in order to urgently decompress. Remember, these conditions are medical emergencies, okay? And they have to be treated as fast as possible. So, going on to neuropathies. What are neuropathies? Some neuropathies, for example, we're going to look at now include ALS, MS, Guillain-Barre, Myasthenia gravis. Again, in all of these cases, we have to always ask ourselves, okay, what is the problem? Is there a neurological problem? Yes or no? Where is the problem? Okay? And how are we going to investigate and treat the problem? So, multiple sclerosis. Multiple sclerosis is usually a polyneuropathy. It usually affects a lot of nerves, and it's going to usually result from the demyelination of the neuron itself. It usually tends to affect young individuals, young patients, usually in their 20s and 30s. It tends to peak at around age 30. Presentation usually results in weakness, sensory loss, ataxias, paresthesias, and optic neuritis. The main diagnostic criteria for multiple sclerosis is that it usually occurs fluctuating between time and space. So, the occurrence of a lesion between one lesion and another usually takes a couple of months. Alright? And when we talk about space, we talk about the lesions present in the brain. When you do an MRI, you see that there is a new lesion in a different aspect of the brain. Therefore, in space within the brain, we have the occurrence of new lesions, okay? And the timing of the lesion is usually delayed. They usually have a positive Lemaitre sign and a Marcus-Gunn pupil, which is a rapid afferent pupillary defect on swinging light test in cranial nerve examination. We can also have internuclear ophthalmoplegia, okay, which might indicate a problem within the medial longitudinal fasciculus, the MLF, and which is a form of ophthalmoplegia, and there are positive upper motor neuron signs and a positive Babinski. So what are the investigations for MS? The next step in our thinking sieve is what are we going to do as an investigation. In MS, you can take a lumbar puncture for CSF and you're going to look at the oligoclonal bands. Usually in MS, patients have oligoclonal bands present in 75% of the cases. There is free kappa light chains, which are more specific, and the white cell counts are usually between 10 to 20, per microliter. Myelin basic protein and myelin oligodendrocyte glycoproteins are also specific for MS. The next step would be carrying out an MRI or a CT scan if you suspect anything else other than MS. For example, we might have a hyper-intensive periventricular white matter patches, which usually are significant if they're over 0.5 centimeters and ovoid, and these patches are usually, as we said before, periventricular. The clinical and the laboratory evidence of a nervous system lesion is always disseminated in time and space. The differential of MS would be neuromyelitis optica, encephalomyelitis, for example by viruses, or transverse myelitis in the spine. We can get a vasculitis, we can get a METS or a lymphoma to the brain, we can get infections like HLV, HIV, HTLV1, syphilis, neurosyphilis, B12 deficiency, vitamin E deficiency, and leukodystrophy. Treatment for MS is usually, we have to treat the patient as a whole, therefore we have to treat depression by giving SSRIs or SNRIs, which are serotonin reuptake inhibitors. We can treat the fatigue by exercise, by providing amantadine, methylphenidate, or SSRIs themselves. Pain can be treated by carbamazepine, which is usually used in epilepsy. We can treat the spasms by baclofen, a muscle relaxant, or a diazepam or clonazepam. Bladder dysfunction can be treated by oxybutynin. And in the acute phase, treatments include steroids and plasma exchange. Relapsing remitting MS may be treated by giving steroids, interferon beta, which is an immunomodulator, galtiramer, and other disease-modifying agents. So, what about ALS? ALS usually presents with bulbar signs, usually affecting the face, the palate, the larynx, the extremities. It presents usually with spasticity, hyperreflexia, and a positive Babinski. In this case, we can see in this patient there are fasciculations over here. And the fasciculations, are classical signs of ALS. Remember, ALS is usually a lower motor neuron problem. It is affecting usually the anterior horn cell. There is atrophy and there is weakness. Labs for ALS and investigations include usually conducting EMGs, which is electromyographies, nerve conduction studies to exclude a possible differential like neuromuscular disorder. We can take a CT of the head, of course, to exclude other neurological causes. So, what is the differential of ALS? ALS usually it can come from a tumor, a structural cause, there might be a deficiency, there may be a metabolic cause, we might have a toxic or autoimmune cause, and the treatment of ALS is usually riluzole, which tends to improve slightly our outcomes. Guillain-Barre syndrome usually has a different presentation to the other neuropathies we saw before. Guillain-Barre syndrome usually occurs acutely and symmetrically. There is usually tingling, stabbing, and pain in the feet, ascending weakness in the legs, arms, and cranial nerves, and mostly it is usually very severe after 14 to 30 days after an infection. Most of the times it is a gastrointestinal infection caused by Campylobacter. It can also, however, be caused by CMV, herpes, and mycoplasma. The patients with Guillain-Barre syndrome are at risk because they have a decreased swallowing and they might require ventilation. Reflexes are decreased or absent, as it can also affect usually the respiratory system. Okay? And it is a muscular problem, a neuropathy affecting the muscles, therefore the reflexes are going to be decreased. Guillain-Barre syndrome, risk factors, is possibly thought to occur because of an autoimmune disease. It is associated mostly with mild respiratory or intestinal infection and progresses over days. The classical finding in Guillain-Barre is an ascending weakness which progresses and worsens over a couple of days, usually 10 to 14 days, and there is a symmetrical paralysis. Here in this guy, in this picture, we can see the ventilator. Most of the times, Guillain-Barre syndrome patients require ventilation because of the failure of the respiratory muscles. So, what investigations can we carry out in Guillain-Barre syndrome? Diagnosis is usually established by carrying out an EMG. The electromyographic studies show a decreased conduction velocity and a partial motor conduction block. If we take a lumbar puncture, CSF will show elevated proteins, however white cells are usually normal. Differential of Guillain-Barre can be botulism, tic paralysis, porphyras, cord compression, diabetes and vasculitis. The main treatment of choice in Guillain-Barre syndrome is plasmapheresis to remove the antibodies, and it is important that steroids can harm the patient in the case of Guillain-Barre. It is important that we intubate and we undergo ventilation, and unfortunately at the end of the day death can occur by autonomic dysfunction and blood pressure fluctuations. So, neuromuscular disorders like Myasthenia gravis. This is an interesting case in order to try and come up with the most common symptoms presenting in Myasthenia gravis. In this case, we have a 30-year-old healthy female who presents with a 2-month history of fatigue. So there is a chronic presentation of fatigue, and there is a 1-month history of intermittent ptosis. So the ptosis is not always present, however, it is intermittent. She has not experienced any proximal muscle weakness, there is dysarthria, there is no shortness of breath, and there is no dysphagia. I meant to say that she did not experience dysarthria, shortness of breath, and dysphagia. Now, the next step would be examination, okay? When we go to examine the patient for the cranial nerves, we're going to look at the presence of ptosis. Ptosis, usually ocular myasthenia, is a common occurrence, alright? The ptosis usually occurs on primary gaze and it worsens with sustained upward gaze. Weakness of the deltoid muscles can also be present, and the most important feature of Myasthenia gravis is their fatigability. The patients will complain of getting worse throughout the day. So, next, what are we going to do? So, we have to think of the sieve, again, the sieve method, where we're going to think about what is the diagnosis, what is the cause, and is there a neurological problem? Yes. In this case, we have Myasthenia gravis, most likely diagnosis because of the fatigability. The best confirmatory test would be to take an acetylcholine receptor antibody, and the next step would be giving treatment to prevent the breakdown of acetylcholine by the enzyme acetylcholinesterase by giving pyridostigmine. What investigations should we carry out? Again, electromyographic studies or nerve conduction studies, which are useful to help differentiate between neuromuscular disorders or myopathies. Okay, where we can conduct a simple test such as forced vital capacity, which is important in evaluating patients suspected of neuromuscular disease in order to assess their breathing capacity, and laboratory studies for acetylcholine receptor antibodies like anti-MuSK antibodies. Okay? A simple test we can also do near the bedside of the patient is the ice test. The ice test usually is the placement of ice on the eyelid for around 2 minutes, and usually if there is myasthenia gravis, the ptosis will improve. Removing the ice is diagnostic because cooling of the neuromuscular junction results in better transmission. This is a case, okay? The next case is a patient who presents with diplopia. This woman is 76 years old and has a past history of diabetes mellitus. How would you investigate this patient and carry out a full cranial nerve examination, alright? Or they might ask you to carry out also a focused cranial nerve examination. So in this case, how would we tend to examine the patient? If we look straight at the patient on observation, we can see that the eye over here is down and out. This points probably towards an oculomotor problem. Okay? The oculomotor nerve is the third nerve. Looking at the pupils, they also seem to be different. This is dilated, whilst this is constricted. Okay? Does this have a significant or important role in our diagnosis? Yes, it does. So how are we going to investigate this third nerve palsy? Okay? We're going to conduct a cranial nerve exam specifically focusing on the eyes. We can take bloods, including a CBC and HbA1c, which gives us a good picture of the diabetic control over the couple of months. We can take a OGT, a glucose, and an inflammatory marker test such as CRP and DSR. C-reactive protein and DSR are markers of inflammation. Ophthalmologically, we can look at the eye, of course, fundoscopically to check whether there's any presence of optic neuritis, okay, or raised intracranial pressure, and in order to see whether or not the diplopia caused by the third nerve palsy corrects, we can undergo a cover and uncover test. Okay? Treatment usually is conservative. It involves taping the eye drops, and correcting the diabetes. The major issue in this case is the diabetes of the patient. So, what is the difference between a surgical and a medical cranial nerve palsy? A surgical palsy is usually a complete transaction of the nerve by a tumor, an aneurysm, and a compression. In the case of the third nerve, we have compression, for example, by aneurysm in the posterior circulation, because the third nerve comes out of the brainstem. Okay, very close to the posterior circulation. Also a very important point in this case is the blood supply of the third nerve. The fibers are supplied by different types of blood supply. Okay? The parasympathetic system, usually in a surgical palsy, is not spared because we have total transaction. Because compression is coming out on the outside of the nerve. Okay? Where the parasympathetic fibers are. Parasympathetic fibers usually travel on the outside aspect of the nerve. Whilst a medical cranial nerve palsy occurs due to microvascular changes, like vasculopathy due to diabetes, and usually spares the parasympathetic system, and therefore we can still have a pupillary reflex. Looking at the anatomy of the pupillary sparing signs in diabetes, okay, we can see how, for example, external compression, okay, of the blood vessels here may cause a surgical lesion, a surgical type of palsy, for example, by a tumor or due to an aneurysm, okay. Whilst the vasa vasorum supply part of the nerve but not the pupillary fibers, okay. It is usually damaged by medical lesion. Medical lesions occur usually deep in the nerve, okay, such as diabetes, and therefore the parasympathetic fibers traveling on the outside of the nerve are spared. Okay? The pupillary fibers lie dorsal and peripheral. As we said again, these fibers lie around the nerve circumference, whilst the motor nerves lie at the center. So we can get a tear nerve palsy, but if there is no surgical compression on the outside, these fibers are spared. Okay? There is sparing of the external fibers, and this will maintain or retain the pupillary reflex because of the sparing of the parasympathetic fibers. So, when trying to differentiate between a medical and a surgical lesion, it is important in order to try and solve our problem and have a solution by managing the type of treatment we need for each case. Okay, a surgical might need neurosurgery if it is an aneurysm, whilst a medical might need correction of the diabetes. Another interesting case we can talk about is a 21-year-old college student who presents with a 4-week history of frequent falls and difficulty jogging. Okay? She is athletic and she states she noticed tripping when walking and falling while jogging. She often stubs her toe, okay, her right toe, and misses steps. What is, again, the most likely diagnosis? In this case, the most likely diagnosis seems to be peroneal nerve palsy and L4, L5. It is easily damaged, the peroneal nerve, because it is present on the outside of the leg, on the lateral surface. The next diagnostic test will be carrying out electromyographic studies of the muscle and nerve conduction to exclude, other causes. And we can treat this nerve palsy by giving ankle-foot orthotic evaluation, okay, or surgical repair. That is the end of our presentation, okay. I hope the video was useful. Thank you very much, guys, okay, and I'll try to do other videos in the future.